Welcome to Advanced Patient Care, the exclusive podcast series by Vance Thompson Vision. Our purpose is to keep you at the forefront of the optometry field through dynamic insights, practical clinical tips, and engaging expert discussions. Join us on a journey of continuous learning and professional growth as we delve into the latest advancements in eye care. Our mission is clear: empower eye care providers with the knowledge and tools needed to provide exceptional patient care. At Advanced Patient Care, we are dedicated to elevating eye care one episode at a time. We talk about, a lot of these things, say excess eyelid skin being kind of a non-urgent situation, but what are things that you're looking for in your office when it comes to managing oculoplastic patients that could turn into an urgent situation?
Yeah, so I would say probably what's one of the more urgent things for us from a lid surgery standpoint is, patients with either like facial nerve paralysis with like a Bell's palsy, that kind of thing where they can't close their eye. I did a surgery like that just a week and a half ago now, where, patient tries to close their eye, it stays completely open. So that poses risk to the cornea. And so we want to act a little bit more urgently. It's not, next day kind of thing, but so getting a gold weight in, doing an ectropion repair, a little small tarsorrhaphy, that kind of thing can help. The other thing that we push a little bit on from a time standpoint is entropion. So when patients have frank entropion and they have a lot of lash cornea rubbing, that can be dangerous to the cornea. And so we'll try to do those surgeries a little sooner. We can sometimes temporize with Botox in the orbicularis to weaken that orbic override and kind of temporarily take the entropion away. But I would say those are some of the things that are a little bit more urgent from an
Yeah,
oculoplastic
that's
standpoint.
That's beautiful. And knowing the anatomy is so important, Zach, because when it comes to, even thinking about maybe orbital tumors,
Mhm.
could you kind of expand on that? We have fat pads in the upper lids, and we have three fat pads in the lower lids. And so, a lot of times that pushing or putting your hands on the patient, if they have some fullness, can really help you to get a sense of if there's anything else going on. And so, not only are we protecting the health of the eye, but we're also looking for things that maybe don't belong. And so, what are some of those things, Zach, that we're looking for when it comes to, possible orbital tumors that could be missed?
Yeah, that's a good question. So like you said, pushing on the eye can be very helpful. So one of the things that I used to do in fellowship a lot and still do from time to time is I'll take both thumbs and put them on the patient's closed eyes and just feel the difference in the sort of the compliance of the orbit. So it's called a resistance to retropulsion. Sometimes you can feel a resistance on one side versus the other. If you think about the orbit, it's essentially a fat compartment. So you can think of it like a ball or like a marble sitting in jelly. And if you push that marble, it should give quite a bit. And if there's resistance to that, it starts to tip you off that there may be something in the closed orbit that is causing that resistance. So that's one thing that when we're pushing on the eye. The other thing that you can do is a quick and simple kind of poor man's Hertel. If you'll have a patient lean their head back and look from underneath, you get what's called a worm's eye view, and you can see differences in proptosis or axial displacement of the globe. So if one eye is in front of the other, from something like a tumor that's pushing it forward, or thyroid eye disease can do this as well. You can a lot of times see that difference with your naked eye without needing Hertels or anything like that. And then the other thing that you're probably going to pick up on in the optometry clinic, if a patient has an orbital tumor, might be something like displacement of the globe. So again, thinking of the orbit as a closed, confined space, it doesn't have a lot of room for extra things. So if you add a tumor in there, it's going to push the eye in the opposite direction. So, if we have a supranasal tumor, we might see the eye move down and out. We might see difficulty with eye movements or restriction in certain directions of gaze. And then the other thing that you can see is refractive changes. So if you have a patient that's having very large degrees of refractive changes over a shorter period of time, or even not so short period of time, depending on what's growing in the orbit, that can be an indication. So if there's a tumor behind the eye that's compressing the eye in its axial dimension, it's going to shorten the eye, and you may get a hyperopic shift. Whereas if you get something pushing on the side of the globe, it can actually lengthen the eye and cause a myopic shift. So that can be something that can actually tip you off as well. And I've seen patients like that actually presented with these refractive changes. But
And I think that's what my point was. It's not always, functional versus cosmetic. Sometimes we have to explore and doing extraocular motility, checking their pupils to make sure they don't have any difference between the two eyes as far as that goes. Other things that we're looking at is extraocular motility, like you mentioned, as well as pupil function. We're looking for a nisocoria that could indicate, ptosis, meiosis. We've all learned about Horner syndrome. And so those are some of the things that we're looking at, as well as lacrimal tumors. I've caught a few of those where it looks like they just have fullness, and you actually palpate and you can feel a mass. And so those are the, things that we're looking for beyond just functional, kind of anatomy, looking at how the forehead moves, looking at how the eye muscles move. We're actually making sure that, the globes are where they should be and in proper orientation. We've kind of covered the functional when patients are covered by insurance, but Zach, let's go into the aesthetic component of oculoplastics. It is an art, and there's so much that goes on in the face, in addition to just droopy eyelids. And so touch on kind of new technology or new techniques that you're seeing when it comes to cosmetic and aesthetics.
yeah, it really is an art. Deb, you're absolutely right. And so a lot of times what we find ourselves doing with the patient on the table is I'll often do this is just stand up and look at what we've done and then just making a true artistic judgment on what's going on. So, you learn in fellowship and in training how to do the technical side of things. You learn how to remove fat, you learn how to put the canthus here and to do the techniques, but it takes one level up from that to be able to actually look at it and say, is this pretty? Is this appealing? And so that's something that takes time to learn, and it's just doing a lot of surgery is where it comes. But yeah, I would say that, cosmetic surgery is a very exciting area to me because of that artistic side of it. Like you said, you and I both like to paint, and we have an artistic side. And so it's fun to get to try to essentially take a very technical skill and use it through an artistic lens. It's an interesting thing to do. And if you asked about kind of the changes that have occurred and the things that are coming down the line with cosmetic surgery, it really is kind of blowing up right now. The number of these cosmetic surgeries are increasing every year. And some of the things that I see, I find the history of these things pretty interesting, but lower blepharoplasty in particular, because as you and I know, upper blepharoplasty and lower blepharoplasty are just two different beasts altogether. The lower
Yeah.
blepharoplasty is far more technically difficult. A lot of plastic surgeons won't touch it. Just because because of that and the problems that you can get with it. And like you said, it comes back to knowing the anatomy and being really comfortable around the eye, especially with lower blepharoplasty. But a lot of the shifts I've seen, over time is that, when lower blepharoplasty was done many, many years ago on the order of decades, it was primarily done from the outside through the skin. And this is still done. But there's, people realize with time that there's increased risk of scarring when you go through these multi-manipulated planes. So going through the middle lamellar or septal plane, you're going to get more scarring and this lid retraction. And so what people started doing was going through a transconjunctival approach, where we actually go from the back side of the eyelid and are able to access the fat pads from the back of the eyelid, and then we can do with them what we want, whether it's reposition them into the tear trough hollow, reduce them, whatever we want to do. But that was found to be a safer approach to prevent lower lid retraction and also offered the benefit of not causing a scar, which is really nice. So that was one shift that kind of, I would say the general oculoplastics community primarily uses that approach. There's actually literature on this that I think it's over 90% of oculoplastic surgeons prefer a transconjunctival approach for lower blepharoplasty. But what I've noticed in more recent times is probably over the last, I would say like maybe 5 to 7 years, is people are starting to really address not just the lids, but really kind of look at the whole mid face when they're doing lower blepharoplasty. So something that's becoming very popular over the last few years is autologous fat transfer to the midface to build up the midface, to build up the tear troughs. And so that's something that I'm seeing incorporated into a lot more cosmetic surgery, is not just focusing on the lid, but building up the periocular adnexal structure around it to make it a more harmonious blend into the face. And so that's something that's coming along. And then also incorporating lasers into our cosmetic surgery. So you and I both do this. We both love our lasers. We just not too long ago
Yes.
got a CO2 laser, which I was very excited about. Um, and so to me, all of these things are additive. So addressing the fat, addressing minute amounts of skin with skin pinching, tightening the
Yeah.
canthal ligaments, doing the laser resurfacing, all of those things add a little bit that when combined really give you the best cosmetic result. Um, and so that's kind of where I see things going right now, is combining all of these little things to give a nice result and trying to be as minimally invasive as possible. Is that kind of your general
Oh,
gestalt around it?
that was beautiful, Zach, because
Thanks,
it
Jess.
is so true. We just don't appreciate that in residency. We're so involved in the, kind of technical piece of surgery like you talked about. But really, if you sit back, what happens in our 30s is we start to actually have bony change. And in our 30s, every decade we lose elastin and we lose collagen in our face. Our muscles become more atrophied over time. And so really you could do the perfect lower lid blepharoplasty or even upper lid blepharoplasty. But if you're not looking at the mid face, especially, to build that up, they're just not going to be as satisfied, especially if they're coming in for a cosmetic procedure. And so, that's where our passion in looking at the skin and reducing wrinkles and brown spots, so age spots, are possible now to do in the operating room. And so, even if they have a functional blepharoplasty of the upper lid, we can still do laser resurfacing to get rid of the perioral wrinkles, to reduce some of, the age spots, to decrease the vasculature on the cheeks, like rosacea, which in turns helps their dry eye. And so that's where Zach and I have become so passionate about really integrating these different procedures for the best results. And then you talk about, what you can do post-operatively after you've had, a cosmetic or functional procedure. And there's things that we can do in the office, whether it's, neuromodulators, where we're actually using Botox or Dysport or Xeomin. There's tons of different, neurotoxins that can help reduce some of these fine lines and wrinkles that are caused by those dynamic muscles in the forehead and around the eyes. We can also do fillers that help build up the cheek or help stretch the chin for patients that, are bothered by their jowls, to avoid a facelift. And then we can continue doing laser resurfacing or laser rejuvenation right in the clinic to really maintain their skin and to build collagen over time. And so that's what I love about oculoplastics. It's not just like a one and done procedure. We can actually do things right in our office to really maintain and to delay that aging effect that we see over time.
Yeah, that's a really good point. And to that effect, we can do some of these surgeries in the office too, even. So a lot of the upper blepharoplasties that we're doing on, some of our younger, more healthy patients that want to be in and out quick, 30 minutes, go home, not have a lot of to do and fuss and in the operating room. We can do some of these in the clinic, and I'll actually do quite a few of those in clinic, and patients seem to really like it, and we're able to do it under just our oral sedation with our melt, same as we use for our cataract surgery patients, and then a little local anesthetic, and they do really well.
Yeah, and I think that people want that and they want to get back to their normal life as quickly as possible.